Okay, so this is the auditory learner. This is going to be the pharmacology study guide, one of the last ones, probably the last one for chapter 18, 16, and 19, which goes over um, diabetes, the endocrine axes, and the corticosteroids, and the menstrual cycle, along with sex drugs. Great. Um, in addition to that, we're going to be, after doing that, we're going to be going over some of the week check-in quizzes, okay, just to make sure we're on top of things. Okay, so let's start with chapter 18 and review of insulin, homeostasis, and diabetes, the drugs for diabetes, and the treatments for diabetes. All right. So one of the first things we need to know is how insulin and glucagon maintain blood sugar homeostasis. Well, first of all, we need to know what insulin is. Okay, so insulin is the signaling hormone molecule that is released by beta cells of the pancreas when the glucose is high. So if a lot of sugar is in the blood, insulin is going to be released. And now the way insulin works is that it attaches to insulin receptors on cells. And then that triggers a GLUT4 channel protein to appear on the cell, which allows the glucose that's going in your blood to go into the cell. And then what happens is that lowers blood sugar levels and brings you back to homeostasis. So this is a negative feedback loop and signals the liver to store glucose into glycogen. All right. So the so when we eat, especially stuff that that has a lot of sugar in it, um, it triggers in a healthy person, it triggers the release of the signaling hormone of insulin from our pancreas through the beta cells when glucose is high. And then what ends up happening is that the insulin, this hormone, attaches to the cells in our body, and that triggers a protein channel, which allows glucose to come into the cell. And that's how this is how blood sugar is lowered and brings the body back to homeostasis. All right, so insulin is important for us to keep our bodies at a normal sugar level. So whenever insulin is sugar is too high, we need insulin to regulate us. Okay, and now, so that's insulin. Now let's talk about glucagon. Okay, so glucagon is the opposite of insulin. It is released, but released by the pancreas as well. Interesting. Very, very interesting. I was of the impression that glucagon was released by the liver. But anyways, let's keep going and see if that changes. Let's see. So if we have low blood sugar, glucagon will be released by the pancreas and signal the liver to use glycogen to release glucose into the bloodstream. This then increases blood sugar. So yes, it does have to do with your liver, except that um, glucagon is released from the liver, from the pancreas when blood sugar is too low. Okay. And then that tells the liver to release, to use glycogen. So then the liver releases glycogen, and that is how we get glucose into the bloodstream. And then that increases blood sugar to normal levels. All right. Um, so that is also part of the normal state, right? So whenever we're very, very low on sugar, glucagon from the pancreas tells the liver to release glycogen, and then that releases glucose into our bloodstream. All right. And so that is glucagon that we just talked about. Okay. That's the role of glucagon. Um, so glucagon can come in a subcutaneous injection as a medication. It's like a bioidentical medication, but this is rarely used and only for hypoglycemia, and it is a hypoglycemic treatment. But this would be for people with diabetes, um, especially they don't make insulin. Yeah. So let's just review type 1 and type 2 diabetes. Type 1, 10% of cases, it's the destruction of beta cells and prevents any insulin. And so that is the treatment is limited. Insulin must be replaced for type 1. Type 2 diabetes is basically decreased insulin sensitivity or basically insulin insensitive. Um, so beta cells are not working as well or they're not responding and produce less insulin. So that means we have more sugar in the blood because we don't have enough insulin to trigger those GLUT4 protein channels on the cells to allow the glucose into the cells, if I'm correct. So, because the pancreas is working harder, now adipose tissues release adipokines, which leads to obesity, and then that counteracts the insulin. And so the different causes, um, what this can cause is can cause many issues, such as like the diabetic foot, glaucoma, cataracts, strokes, peripheral neuropathy, etc. Many long-term risks. Okay. Um, we're gonna go into now the types of diabetic drugs that we have. Okay. So let's get into that here. Now, drugs for diabetes. All right. So we're talking about here insulin preparations. Okay, so there's rapid acting, short acting, and long acting insulin. The rapid acting is called insulin aspart or Novolog. The second one is called insulin Lispro or Humalog. Okay, so when we're thinking rapid acting, they have the log at the end. Okay, insulin aspart, insulin Lispro. Short acting is insulin regulator, Novolin, or intermediate acting or insulin NPH, Humulin N, Novolin N. Then there's long acting insulin, which is insulin detamir, which is Levemir. The next type of diabetic drugs are sulfonylureas. I hate that word. Sulfonylureas. Um, these end in ide. So we got glympyride, which is Amaryl. We got glipizide, which is glucotrol, and glyburide, which is diabeta. Then we have the meglitinides. And interestingly enough, the generic name for this also ends in ide. Meglitinides have nateglinide and metiglinide. Nateglinide is Starlix, metiglinide is Glufast. Then we have the DPP4 inhibitors, which are linagliptin or Tradjenta, and sitagliptin, which is Januvia. Then we have biguanides, which is metformin, which is the one we know, which is it's called glucophage. Then there's an alpha glucosidase inhibitors, which is acarbose or precose, and then miglatol or glycet. Then there's a GLP-1 receptor agonist, which is dulaglutide, Trulicity, liraglutide, Victoza, or semaglutide, Ozempic. Those are GLP-1 receptor agonists. And there's SGLT2 inhibitors, which is empagliflozin and ertugliflozin. And then there's amylinomimetic agents, which is pramlintide or Simlin. All right, so let's get back into this diabetes thing, okay? Um, so we're going to explain the uses of insulin and its adverse reactions and the pharmacokinetics and administration. So supplemental insulin or insulin injections, those are basically metered auto injectors used for type 1 only and is a gold standard for type 1. And type 2, we can use it sometimes, but mostly type 1. It's made from a genetically engineered E. coli, which comes in rapid acting, short acting, or intermediate acting, or long acting, which we just spoke about. This is all up to the doctor. So the pharmacokinetics of these types of insulins, they're taken subcutaneously and they're injected into adipose tissue, because if they were to be taken orally, the bioavailability would be zero, almost zero. And so pepsin in the stomach will inactivate it, and it's metabolized by the liver and the kidneys. So adverse reactions to supplemental insulin injections is the swelling, pain, or redness at injection site due to poor technique or perhaps an allergy. Most common is hypoglycemia by improper or too frequent dosage, which causes lightheadedness, lethargy, or headaches. Glucose always needs to be in the blood. Yes, that is how a normal physiological body homeostasis is. There has to be glucose in the blood always. Now, it says here to list drugs that can be used for hypoglycemia and how it can be prevented in the first place. Where glucagon, which is, we spoke about that previously, that is one of the drugs used for hypoglycemia. But prevention of that is making sure patients have had a meal recently and taken their medications prior to their appointment, which should be usually in the morning. Emergency glucose sources are always ready in the emergency kits in the office, such as cake icing, which is preferred to glucagon because it has less adverse effects. So some sort of sugar should be taken when we see people experiencing lethargy, lightheadedness, or headaches. Something that makes them look like they're just kind of slowing down, shutting down. Also, we're going to explain how sulfonylureas and meglitinides are used and how they work. So sulfonylureas are the oldest drug for type 2 diabetes, and only when not responding to exercise and diet. Okay, one of these sulfonylureas drugs that we talked about is called glyburide. Glyburide is taken by mouth for increased insulin secretion, which depolarizes the beta cells and prevents potassium efflux. One of the adverse reactions of glyburide is hypoglycemia, which is from too high of a dose or being fasted. Weight gain is another because the body is using sugars more than fat. And drug interactions, aspirin should be avoided because it can lead to hypoglycemia. That was for sulfonylureas, okay? So type 2, the oldest drug, glyburide, taken orally, and adverse reactions to hypoglycemia, weight gain, because the body's using sugars more than the fats. Don't take aspirin. We're going to talk about meglitinides, okay? Similar to sulfonylureas, but different mechanism of action. Similar adverse reactions as well as high. So everything we just talked about, sulfonylureas, same things for meglitinides, except that aspirin does not affect it. But if you were to take one of the antibiotics of clarithromycin, a macrolide, that does affect the effect of meglitinides. Okay, now GLP-1 agonists and DPP-4 inhibitors and their usage. So GLP-1 agonists, these are newer drugs. There's a lot of marketing for these. These are taken subcutaneously for type 2 as well. So far we've only been talking about type 2 diabetes drugs, but they're also used for obesity or weight control. So the drugs that are used as GLP-1 agonists are dulaglutide, which is Trulicity, semaglutide injection, Ozempic, and semaglutide PO, Rybelsus. Um, Ozempic was changed to Wegovy for weight loss, and it's very expensive. Incretins, those are hormones released by the GI tract to stimulate or to food stimulations which stimulate the pancreas to reproduce insulin. So incretin effect is when taken orally, is when PO glucose stimulates more insulin than IV glucose. All right, so there you go. That's incretin is a hormone used to stimulate the pancreas to produce insulin. Let's talk about DPP-4 inhibitors now. They're similar to GLP-1 agonists, but different mechanism. They prevent the degradation of endogenous GLP-1 by inhibiting DPP-4. And inhibiting an inhibitor, basically. It causes weight gain. Okay, so this causes weight gain. Now we're going to talk about alpha glucosidase inhibitors and amylinomimetic agents and SGL2 inhibitors and metformin. Alpha glucosidase inhibitors, they inhibit the breakdown of polysaccharides, which slows the absorption of carbs and allows for more time for the pancreas to release insulin. One of those drugs are called acarbose or precose. And this alpha glucosidase inhibitor's adverse effect is farting, basically, which is flatulent and GI upset. The amylinomimetic agents are pramlintide or Simlin, and they're given subcutaneously, mimics the hormone amylin to prevent stomach empty. It slows the absorption of food as well. It's useful for type 1 and 2, okay? Then there's SGL2 inhibitors, which stops absorption of sodium and glucose in the kidneys. This lowers blood sugars and helps for cardiovascular disease as well. But the adverse reactions for this are an increased risks for UTI infections because sugar in the urine and hypotension, hyperkalemia as well, and renal disease patients are contraindicated. Hyperkalemia, as we know, is too much potassium. Then we got the biguanide drug, which is metformin, is the only member and the first choice for type 2 diabetes. And it's taken orally, either immediate release or extended release types are available. The mechanism of actions are still unknown. This does cause metallic taste in the mouth and increases lactic acid without food and GI upset. So there it is. We now understand a lot better diabetes and the drugs for diabetes. Okay, so we talked about what insulin is and how it works. We talked about glucagon and how that works, right? How they have an inverse relationship. One brings sugar levels up, one brings sugar levels down, but they basically both are the same in the fact that they both help bring the body back to a homeostasis or to a normal level in a normal patient. It is when we have diabetes that it affects the way that we use insulin and glucagon. Anyways, we talked about that, type 2, type 1 diabetes. We talked about the drugs and how they work and some of the adverse reactions, how mainly type 1 is the subcutaneous insulin injections. And then we talked about all these type 2 diabetes drugs, which some of them are used for type 1. Whew, okay, what's next? Now let's talk about the endocrine system and adrenocorticosteroids. All right, so let's describe the major hormonal axes of the body. So first, we need to know that it starts at the brain. We have the hypothalamus, which is part of the brain and the nervous system, which regulates the pituitary by stimulating it to release trophic hormones. And this is done via the hypophyseal portal, which is basically blood vessels and capillaries that connect to the hypothalamus and the anterior pituitary. And it is connected by neurons from the hypothalamus. So the hypophyseal portal is, from my understanding, only in the anterior portion of um, the pituitary. Now, let's talk about the posterior pituitary. There's a long axon neuron that does neurohormonal signaling on the posterior portion of the posterior pituitary. It produces peptide hormones such as oxytocin, which is the cuddle drug, vasopressin, antidiuretic hormone, which prevents urination. So now everything else that we're going to talk about has to do with the anterior pituitary, and there is a couple axes that we need to be aware of. There's the HPA, which is the hypothalamus pituitary adrenal axis, the HPT, which is the hypothalamus pituitary thyroid axis, and the HPG, which is the hypothalamus pituitary gonadal axis. The HPA, which is the hypothalamus pituitary adrenal axis, that's when the hypothalamus tells the anterior pituitary to produce cortisol by releasing cortisol releasing hormone, CRH, into the anterior pituitary, which then produces adrenocorticotropic hormone, or ACTH, to circle in the blood. But adrenal glands are the only organ to respond to adrenocorticotropic hormone, which makes adrenals to produce cortisol. It is self-regulating. Stress is self-regulating. This is a negative feedback loop. The liver, so just some things about this. The liver goes through gluconeogenesis. Muscles go through protein catabolism, and adipose tissues go through lipolysis. All right, so when we think HPA, we want to think cortisol because adrenals. And adrenocorticotropic hormone release and cortisol releasing hormone. Okay, now when we think HPT, we're thinking hypothalamus pituitary thyroid axis. This controls thyroid secretion. So thyroid releasing hormone goes to the pituitary, and the pituitary releases thyroid stimulating hormone. And the thyroid gland, which is here around the neck area, inferior to the Adam's apple, then produces T4 and T3. The metabolic effects increase metabolism. This is also a negative feedback loop. So when we think HPT, we want to think about the thyroid and metabolism. Okay. TRH, TSH. Now, HPG, hypothalamus pituitary gonadal axis. This is when the hypothalamus produces gonadotropin releasing hormone, and the pituitary then releases luteinizing hormone and follicle stimulating hormone, which goes to the gonads or the ovaries to produce testosterone and estrogen. This is also a negative feedback loop. All right. So gonadotropin releasing hormone, luteinizing, and follicle stimulating. So again, just to review, the adrenal glands release cortisol from CRH and ACTH, which can be anti-inflammatory, and in an immune response for target tissues, cortisol is released from the adrenal cortex. And epinephrine is released from the medulla. Those are quick sources of energy to prepare for an event. Again, the thyroid gland releases T3 and T4, which are built using iodine, and thyroglobulin, which is a colloid, to increase metabolic rate, also secretes calcitonin to lower blood calcium. So the thyroid gland also has a function in which it releases calcitonin to lower blood calcium. The gonads we know. So one thing we want to know is that if we see a line with dots, that means something is inhibited. If we see an arrow, that means something is activated. Okay, let's talk about the adrenocorticosteroid hormones now. Adrenocorticosteroid drugs. So generally, ones taken orally or PO are dexamethasone, prednisolone, and methylprednisolone. There's some that are taken topically and are insufflated, and those are from starting from the super high potency, which is clobetasol propionate, from high potency, which is fluocinolone acetonide, and medium potency is triamcinolone acetone or aristocort, and then betamethasone valerate, which is valacone, and then low potency hydrocortisone, which is Cortade or Democort or all these other names. Okay, so super high, medium, low, and adrenocorticosteroids. Um, Back to what we were talking about here. Let's talk about what some of the diseases like Cushing's and Addison's. Okay, Addison's disease is when there's insufficient adrenal output. So it means again, your adrenals produce cortisol, so that means that you're not producing enough cortisol. Um, and so you might not be ready for things as you should be, so you might experience extreme fatigue, dehydration, something called vascular collapse or renal shutdown, very low sodium or very high potassium. Some signs of Addison's disease is bronzing of pigment of the skin, changes in body hair distribution, weakness, weight loss, hypoglycemia, and postural hypotension. So we can see that these people are weak, right? They're not ready for events. Then there's Cushing's disease, which is basically the opposite. It's the overuse of corticosteroids, also overproduction of cortisol in the body. So signs of this is thinning of hair. There's a buffalo hump on the top back of their neck. They have a moon face. It's increased body hair and facial hair, easy bruising of the skin, slow wound healing, thin extremities with muscle tissues, glaucoma, osteoporosis, and behavioral changes. So going back to the drugs that we talked about, we're going to explain how adrenocorticosteroids work. Used for inflammation and allergies can be very powerful since they mimic cortisol. They're better than NSAIDs because they suppress the majority of the immune system and not just COX-1 and 2. So rashes, bug bites, allergic rhinitis, eye drops, asthma, general inflammation, non-infection oral lesions, and post-operative inflammation and swelling. These are all reasons why people would take adrenocorticosteroids. Should be careful with infection. We're going to list the adverse reactions of adrenocorticosteroids. Probably wasn't too much on this, but we just know that when the dose is too high or too frequent, it's when you get browning of the skin, is an adverse reaction to exogenous adrenocorticosteroids. And the way that adrenocorticosteroids should be used during surgical procedures and who can take them. So there is a negligible patients with adrenal insufficiency currently taking daily oral steroids. All right, these people, if they're getting some work done, there really is not much risk. If it's a non-surgical procedure, no supplementation is necessary. But if these adrenal insufficient, so people basically with Addison's disease is what we're talking about here. People have Addison's disease and they're taking daily oral steroids, there's that we talked about the negligible risk. Now there's a minor risk. Minor risk for oral surgery. So few simple extractions, minor periodontal surgery, 25 milligrams HC or 5 milligrams prednisone day of appointment. However, there's a major risk if they're doing major surgery, okay, such as like osseous osteotomies, bone resections. Um, that's going to have to be with the doctor. Okay, so now we're getting into the last chapter, 19 here. Let's talk about that. We're going to talk about the classification of other hormone drugs, thyroid drugs, and sex hormone drugs. So estrogen and progestins, how they play a role in the menstruation is when the endometrium in the uterus is shed and ovaries release eggs. Menarche is the first day of the period, and and menstruation lasts about 28 days. The first 14 days are ovulation or the follicular phase, and the last 14 days are the uterine phase. Estrogen, as ovarian follicles secrete estrogen and thicken the endometrium, um, growth of the endometrial glands, and growth of spiral arteries, and change consistency of cervical mucus, which is good for sperm and fertilization. This is the highest between day 11 and day 15. All right, let's talk about the hormonal drugs. Um, and thyroid drugs as well. So for thyroid drugs, treatment for hypothyroidism is levothyroxine sodium, which is T4, or Synthroid, and liothyronine sodium, which is T3, or Cytomel. That's for hypothyroidism. Hypo is Addison's. And then treatment for hyper which is basically Cushing's. That would be propylthiouracil, PTU, or methimazole, or tapazole. Now there's hormone drugs. For females, there's conjugated estrogen, which is Premarin. There's estradiol transdermal system, which is Estroderm. There's estradiol estrase. There's medroxyprogesterone, Provera, and norethindrone, Micronor. Then for females continuing that, there's contraceptives, which is Sprintec, Junol FE, and Apri. For males, there's testosterone cypionate and testosterone ethionate. And then there's other ones such as anastrozole, Arimidex, clomiphene, Clomid, tamoxifen, Nolvadex, finasteride, Propecia, and dutasteride, Avodart. Okay, we're gonna now go back to the lecture thing here. So explain what hypothyroidism and their effects on the body. So just a reminder, when you think Addison's and Cushing's, we're thinking cortisol, all right? Adrenal insufficiencies. When you're thinking, so that's hypo, yes. So hypocortisol is Addison's and hypercortisol is Cushing's. Now we're talking about hypothyroidism and hyperthyroidism. Okay, don't confuse those. Hypothyroidism is Hashimoto's. All right, that's an inadequate hormone production, often by malnutrition or as an autoimmune disease. It causes mental and physical delays in children, such as tiredness, weight gain, depression, large tongue, large lips, inflamed gingiva, and delayed tooth eruptions. In adults, it's just tiredness and weakness and weight gain and depression. There's no oral symptoms in adults. The lack of iodine can prevent formation of thyroid hormone and can lead to goiter. So there's primary, secondary hypothyroidism. Primary Hypothyroidism is the brain portion, so the hypothalamus and the pituitary is working fine, but the thyroid itself is not producing the hormones it needs. That's primary. Secondary is the brain portion, but the pituitary only is not working, but the thyroid is working. Okay. So just to simplify this, primary means that the brain is working, the brain portion is working, but the thyroid isn't. That's primary. Secondary, the thyroid is working, but the brain portion is not working. Okay, so now drugs that are needed. We talked about that. There's levothyroxine sodium, which is Synthroid, which acts as T3, and liothyronine cytomel, which acts as T4. Both are taken by mouth. Adverse reaction for this is the opposite of hypothyroidism, which is hyperthyroidism. If taken too much or too high of a dose. If treating a healthy person, it might give them hypothyroidism when they stop. So doctors, be careful. Now, there's hyperthyroidism, which is Graves' disease, okay? That's too much thyroid hormone, and it's often caused by autoimmune Graves. So symptoms are hyperthermia, increased sympathetic activity. So the heart rate, anxiety, weight loss, insomnia are symptoms, as well as accelerated tooth eruption, loss of alveolar process, demineralization of the mandible, and protruding eyes as well. Treatment is ablation using radioactive iodine by destroying cells or a thyroidectomy. But if any of those are contraindicated, then they can use an antithyroid drug such as propylthiouracil or methimazole. But usually it starts with ablation by using radioactive iodine or destroying the cells or thyroidectomy. Now, let's talk about hypogonadism in females. Usually caused by menopause and is characterized by hot flashes, osteoporosis, chills, thinning of hair, weight gain, and slowed metabolism. Also caused by lack of menstrual cycle, so no more estrogen and progesterone. Treatment of female hypogonadism is estrogen replacement or progesterone replacement if the uterus is present. So estrogen replacement or progesterone replacement if so only progesterone if the uterus is present. Used at the lowest dose for a small period of time because of increased risk for stroke, breast cancer, and venous thrombosis and coronary artery disease. Used only when severe and limiting. So progestin is not always required for the treatment of hypogonadism. Okay, now contraceptives are estrogen and progestin as drugs, which can be given oral, vaginal ring, IUD implant, or long-term injections. Tricks the body that ovulation has already occurred. Allowed with oral and PO, and women given 21-day pack with 1 week for menstruation. 28 is 7. All right, so that's female hypogonadism. Male hypogonadism is caused by obesity, genetics, unhealthy diet, or testicular damage. Leads to low sex drive, decreased muscle mass, weight gain, and loss of pubic hair. Okay, treatment is testosterone replacement therapy, TRT. If this is used cosmetically in healthy patients, it will atrophy the pituitary and the testicles. Okay, not good. TRT is given subcutaneously or intramuscularly on a weekly schedule. And it's deposited into the fat, kind of like insulin. Other major sex hormone drugs are clomiphene, which stimulates gonadotropin-releasing hormone, which causes ovulation in women and testosterone production in men. This has no pituitary or testicular atrophy in men. So that's the only good thing about it, except that it's just not as high as testosterone therapy. Okay, finasteride and dutasteride. All right, these drugs block the 5A reductive enzyme that convert testosterone to DHT, dihydrotestosterone. Dihydrotestosterone is responsible for prostate growth, pubic hair growth, and male pattern baldness. So, dutasteride can shrink the prostate if it has grown. Okay. Finasteride slows down balding but prevents pubic hair growth. So, finasteride blocks DHT formation. Okay. Um, Also, anastrozole, it stops aromatase and converts androgens to estrogens. And anastrozole is used with women with breast cancer and stimulates breast growth. It's used for men with too much estrogen, gynecomastia, and causes xerostomia. Then there's tamoxifen, which prevents growth of breast cancer, antagonizes receptor in the breast. Great. So hopefully that makes total sense. Um, we're going to be going now into the review of the week 4. Okay. Um, so let's do that now. Let's do that now. Let's go here. All right. So this is going to be a review of the week 4 check-in quiz. This one is going to be going back to the previous videos where we talked about uh, antihypertensives, statins, also the allergic rhinitis, asthma, things like that. Okay. Um, Also antihistamines and things like that. Okay. So first of all, let's get this out of the way. Propranolol is a beta blocker. Chlorothiazide is a thiazide diuretic. Spironolactone is potassium-sparing diuretic. Metoprolol is a beta blocker. Calcium carbonate is an antacid. Vasotec is an ACE inhibitor. Ivabradine, drug treatment for heart failure. Ranolazine, drug treatment for angina. Okay. Amiodarone is an antiarrhythmic. Lipitor is a statin. Nexium is a proton pump inhibitor. Benadryl is a first generation antihistamine. And Fleet is a laxative. So, question number 2: what long term cardiovascular disease is described by the inability of the heart to pump enough blood? That's going to be heart failure. Okay. The majority of patients with hypertension require at least 2 drugs to manage their blood pressure. That's true. Which antihypertensive causes both vasodilation and decreased sodium absorption? That's going to be ACE inhibitors. Okay. Which of the following best describes the mechanism of ivabradine? It blocks the funny current. Okay. Which of the following is an adverse reaction of digoxin? Is arrhythmia. Nitroglycerin may cause a patient to faint when getting up from the exam chair. That's true. Which of these is a last choice drug for angina? It is ranolazine. Okay, which antiarrhythmic class inhibits slow inward sodium channels? Class 1C. Which of these is generally true about statins? They decrease VLDL levels. Okay. How long does it take for warfarin to have its effects? 3 days. What digestive disease is characterized by frequent acid reflux due to issues of the lower esophageal sphincter? That's going to be GERD. Which digestive system drug blocks release of stomach acid by the HK-ATP protease pump? That's Prilosec. Which of the following can cause QT elongation as an adverse reaction? That's going to be H1 blockers. Pepto-Bismol likely has antibacterial effects. That's true. What type of laxative increases the size and water retention of the feces? That's going to be the bulk type of laxatives. Uh, which class of drugs does not act as an antiemetic? That's going to be the adrenergic blockers. Asthma is a form of COPD. That's false. It's reverse. It's COPD is kind of like a form of asthma. Here we go. Choose all that apply. Which class of medication will likely be most effective for severe asthma? So that's long-acting sympathetic agonists, corticosteroids, and anticholinergics. Albuterol has a half-life of 30 minutes. That's false. What is an adverse reaction to inhaled anticholinergics? Xerostomia. Which of these is true about both first-generation antihistamines, but not second-generation? First-generation antihistamines cause sedation. So second-generation antihistamines do not. Great. Very good. All right. So let's end this session for today. We'll do more if we need to later. Good luck on passing the exam, bro.